Hello, everybody, and welcome to this special webinar by the International Academy for Clinical Hematology. As you may have noticed, we are organizing these weekly special webinars in this very special period related to the COVID-19 crisis. We believe it is crucial to continue to share knowledge and exchange experiences and try to be useful to the medical community, but also to the hematology patient. As a matter of fact, before starting this webinar, I'd like to have a special thought to all victims and families and all those guys fighting against this coronavirus pandemic. All together, we will be able to overcome. For this special webinar tonight, it is my great pleasure to welcome Dr. Annalisa Ruggeri from the Institute San Raffaele in Italy. Dr. Ruggeri is a very well-known investigator in the field of bone marrow transplantation and hematology in general. She has published some pioneering work, and she has been over the last few weeks in the middle of this COVID-19 pandemic emergency, and she was part of the team who led the preparations and allowed their hospital to continue to function and to deliver state-of-the-art care to hematology patients. So, Dr. Ruggeri, despite your busy time, we are very grateful that you managed to join us today for this webinar, and we are very eager to share with you your experience and to learn from you about how you have handled this very difficult situation. And when we have prepared this webinar together, I think you shared with me some of your objectives highlighted here. So thank you for joining, and please let us know what was the spirit when you started facing this pandemic.
Good evening, and thank you, Mohamad, and thank you, the International Academy of Clinical Hematology, for keeping and continuing on organizing this very important meeting for discussing and sharing the experience from some part of the world which are facing this true pandemic. Since the 20th of February, actually, in Italy, in Milano, we had the first patients diagnosed with COVID-19 infection. This was a young man without health history of any disease. And actually, since then, we are now with more than 120,000 people affected in the entire Italy. So we are facing really a dramatic moment, and this is the moment where the huge effort to face this very severe disease is on place. So I used to work in the Hospital San Raffaele in Milano, which is a tertiary care hospital with approximately 1,300 beds, with a very huge bone marrow transplant and cellular therapy program, but also every other specialty are in the institute. Since then, our program in the bone marrow transplant and cellular therapy unit did not stop. We try to keep all the patients because, of course, COVID-19 is a huge and dramatic situation, but hematological disease are also life-threatening, and patients need to be treated and cured. Since the end of February, we started to prioritize some patients and to try to have some indication of what would be the urgent transplant to be done or the urgent treatment to be provided to the patients. But of course...
Annalisa, before going into the details of the prioritization, so do you confirm that actually the major goal was to maintain the delivery of the highest level of care to the hematology patient, including the relatively sophisticated therapies like bone marrow transplant and cellular therapies? I'm insisting on this because we hear more and more that patients are really anxious about the idea that maybe they are becoming like a sort of a second class or second zone priority while everybody and all resources are focused on COVID-19. And I would like to hear that from the heart of the battle, because Italy has paid a very, very hard price in this COVID-19. You managed to continue your cellular therapy program.
Absolutely. And this is exactly what I would like to highlight since the beginning, because we didn't stop our program because patients need to be treated with the highest level of cure, and also treatment like the cellular therapy and the CAR-T cell product or the gene therapy product need to be delivered on time for the patients who are in need. Also, we organize a really reshape of our activity, but the main objective was to continue to treat the patients as we were done before the COVID-19 outbreak.
So how many transplant procedure and cellular therapies were you able to perform over the last, let's say, 6 weeks?
So since the usually we perform 90 allogenic transplantation per year, and over the last 6 weeks we perform 4 allogenic transplantation, and 1 patient was treated with cellular therapy.
Amazing.
With CAR-T. So, but this is very important, and really patients treated for hematological disease need to felt like our prioritize, and this is very important because when we discuss with the patients, we try to avoid at maximum to come to the hospital for like concentrating all the tests during one day in order to avoid them to go and back from the hospital several times. And also I will tell you how we have organized for the family donor the pathway for the family donor in order to be always on time when the dedicated transplant date is chosen. So one important point that when we started facing the increase in the number of patients who were admitted at the hospital for the COVID infection was firstly the reorganization of the hospital with a dedicated pathway for the COVID-1.
So that brings me to my first question, which is now shown on the screen. Is how did you organize the clinical activities? Because we know in hematology in general, you have the outpatient unit, you have the leukemia unit, the lymphoma, myeloma, transplant. So, and then the question is, how did you define the so-called urgent versus non-urgent therapies?
Yeah, thank you for bringing these 2 points. So the first point is once the hospital was affected by the arrival of the COVID-19 patients, we promptly decide to have a COVID-dedicated pathway, starting from the emergency room to the radiological test, laboratory test, and also the dedicated ward. This, of course, was an increasing process because we were adapting the unit according the number of beds dedicated according to the demand from the emergency room. We have a peak of more than 70 patients per day reaching the ER daily. So once we started that, we still kept doing our activity like preserving our patients' deadline. So 3 main points were discussed. One was the availability of ICU beds for patients in the hematological unit. And in the reorganization of the hospital, where we have now more than 70 beds dedicated in ICU to the COVID, we keep 10 beds clean for the most sophisticated treatment, and the hematological unit has a priority for this. And also,
let me ask you 2 questions in relation with this very impressive organization, because first of all, you said that you have different pathways. Did you dedicate staff, specific staff and healthcare workers like nurses to those patients who are suspected versus, you know, the non-suspected COVID-free patient?
Yes, actually, all the patients who are suspected are treated like positive by default until the results of the nasopharyngeal swab. And we have a dedicated unit a dedicated area in the emergency where the doctors and the nurses working in the emergency are those responsible. But also, since we reshape the entire hospital with almost 270 beds nowadays dedicated to the COVID patients, we have a dedicated staff which is done by people from infectious disease and internal medicine. But of course, we had some volunteers among doctors, among residents, among nurses who want to join the dedicated unit. And in that case, they are no more belonging to the original unit in order to avoid any contamination. So we have, this is very, very interesting because this allows to have really a multidisciplinary teams with infectious disease, hematologists, ophthalmologists, neurologists, all coordinated by the internal medicine and infectious specialists, but the staff is multidisciplinary and is working like in a separate organization, not going more back to their own unit. But this.
So if a hematology patient needed, who is COVID positive and needed, let's say, hematology treatment, so this has been delivered in the COVID positive multidisciplinary unit under the responsibility of ID doctors, internal medicine, etc. Is this correct?
Yeah, so actually in this different unit dedicated to the COVID, we have some like sub-specialists. So we organized a hematology COVID unit where we can have patients, because several, actually from our staff of hematologists, we have now 8 doctors who work in the COVID department, we can say. So those doctors are also in charge of the hematology patients who are treated for pneumonia or also have to do some blood transfusion because they are under treatment with aplasia and needs platelet transfusion. So we were able to organize a hematology unit for deliver the urgent care to those patients with COVID positive.
So this is really very, very well structured and great, and you should be really praised for this. So you mentioned also the issue of intensive care beds, and we know that the hematology activity in general is a big provider of ICU patients. So out of your several dozens of beds ICU, you said you dedicated 10 beds which will continue actually to receive the non-COVID patient, and your hematology activities are part of them. So how this has been organized?
This has been organized because, of course, the normal and urgent activity of the hospital need to continue. The daily surgery or other consultancy that could be delayed were, of course, postponed, but the needs of operatory room clean with dedicated staff and also the ICU beds ready to admit all the patients who could benefit of intensive care for other diseases rather than COVID are well organized. And so this allows us to have like a self-protected activity, and we can keep our transplantation, we can keep our CAR-T program or all other induction chemotherapy for a new diagnosis of acute leukemia. Of course, other treatment who can be delayed, like some autologous transplantation and other allogenic transplantation for other kind of, for instance, of non-malignant disease, was postponed to another moment. And other important point that we organized in order to protect our patients was the telemedicine. For those patients who are not in the ward but who are followed in the clinics, we were able this month in March from colleagues from our clinics treated almost 50 patients by e-health assessment in the telemedicine, talking with them via video call and sharing the blood test. And of course, for those who are in follow-up, but we can postpone the follow-up clinics. But for some patients, like the patients treated for GVHD, needs to be followed very carefully. So not to miss them and not to miss the opportunity to have a point of contact with them, we keep with the telemedicine. And we also address to those patients newsletter and very well structured information on how to deal with some relatives who can be sick or what to do via email or via newsletter in order to let them very carefully updated.
So let me, this is wonderful, and I think now telemedicine has been adopted almost everywhere, and suddenly most of us realized that actually you don't need to bring 20 patients into your consultation, and you just maybe 2 patients, and all the rest you can do it. And even, I mean, I have noticed this with the elderly patient, where everybody thought, oh, no, the elderly, you know, they don't have the equipment, they don't like, you know, technology. Well, actually, they are brilliant. Our elderly patients have a capacity to adjust and to do things in an amazing fashion. Let me go back, Annalisa, to the dedicated pathways, because you mentioned the patient arriving to the emergency room and then sort of a triage, whether COVID positive, not positive. And then you mentioned the COVID positive units, where you had all the volunteers, the doctors, the nurses, all the healthcare professionals, including hematologists, which actually allows to take care of the hematology patient, the state of the art. And then you mentioned in the ICU that you have the COVID-free beds. So my question, because I have several discussions with many colleagues that the hematology physicians who are volunteers to go in the COVID positive units, are they coming back to the hematology department and seeing the other patient, or you created a sort of a separation for the time being? Because one concern we have is a relatively high rate also of contamination of the healthcare professionals, especially in the beginning of the pandemic and the beginning of the crisis, because we had less knowledge about, this virus. So how did you organize the staff? Who is doing what and where?
So thank you. Actually, this is was very critical when we decided to split our staff, because the colleagues who are taking care of the COVID patients and the COVID unit, and also we have to say that this is really a huge effort, because the patients in the daily activity of the COVID units are very heavy, with a lot of support of oxygen. So it's not an easy activity. So those colleagues are no more allowed to come back to the unit. No, neither the doctor, neither the nurses. So they stay in the COVID units until we will discharge the last patients, hopefully. So we reorganize our activity with the remaining doctor, but all of those who were committed to go on a voluntary basis, or they decided to go there, are no more part of the routine in the hematological activity. And this is very important, because we need to avoid the contamination, and also our weekly meeting and the staff are now done on a web-based call, because we try to stay as much as we can far one from the other. We wear the mask every day in our activity. We use the surgical mask, and in case of patients who has respiratory symptoms, then we use the FFP2 mask with the surgical mask on top. And one important point that I want to share, because I think it's very useful, is what we are doing for those patients who came to the day hospital and have to do like chemotherapy from myeloma or other kind of activity and control. If they are under, we call them every day, the day before. Every patient who are admitted to the day hospital for tomorrow are called today, and we have a check with them about the symptoms. And if some of them have symptoms, they came, but before coming to the day hospital area, they go directly into the unit, into a dedicated area for suspected patients with hematological disease, where they received the blood test, but also the nasopharyngeal swab, and we wait for the response before carrying him in the general day hospital. So this is really, on a daily basis done. So we need to have call every day for the patients, but this avoid the contamination of the patients. And of course, patients arrive alone with no accompanying person, and also in the in-ward activity, they are alone, but all of them can share via internet their feeling with the family. And another important point is that we perform the nasopharyngeal swab at the entry in the hematology or the bone marrow transplantation ward, and until the results that we are able to provide in less than 3 hours, they are treated like suspected positive. So the nurses came into the room with a particular dress, and we try to really reduce as maximum the contamination and the contact within the unit. And this so far was very effective, because we have we have 4 cases of patients with hematological disease. So actually, 2 of them are transplanted patients, and they are doing well. They with no need of intensive care. So I think this model is a very fruitful model. And
if I so the key words, my understanding for what you said is the dedication of the healthcare workers, because being available all the time, calling the patient on a daily basis, and then the second key word is about anticipation. Always be ready and try to anticipate what's going to happen. But also I can sense a third keyword, because this is very, very impressive, is about reactivity and speed to get the results of the PCR of the swab in less than 3 hours, which is really, really very quick. And then, because we'll talk about the anxiety of the patient, of the staff, and everybody, and the waiting time is something extremely very hard to stand or to be to manage for the patient and for the staff.
Yeah, and also I think that something really, really important is that we explain to the patients that we are facing something that we don't know. So this put all together us as physicians, as nurses, and the patients like human beings. We don't know, we were not expecting what happened. So actually patients do not complain, because we are doing as much as we can in order to provide the treatment, to get them the prescription on a quick time. But it's really important that, and also we organized, the first time it was 21 of February, but then we updated, facing the different situation that we are living, we update our procedures in order to be more reliable with the time we are being. So this is really an effort, a big effort of the staff, and it's really this dramatic moment that makes us in a very huge solidarity. So we are not having any disruption in our activity, and we come back at home, of course, after long days, but very successful, because of the organization is effective. So I think it's a matter of really consider that we don't know, and we need to be effective. And
so I can add 2 keywords here from your message: being humble, because we don't know, and we heard this very well, and I hope everybody would agree with us. We need to be humble when facing this COVID-19 pandemic, but also, you mentioned it, solidarity. There is no room for the small, I would say, fights and the small politics there. We have to go in the same direction. So maybe let me ask you now a very practical question again, because this is going to last probably for several weeks. And unfortunately, I didn't notice that the incidence of acute leukemia, for instance, or non-Hodgkin lymphoma or myeloma is decreasing using COVID. We keep on having, these newly diagnosed patients. So maybe you have already had this scenario, or if you didn't have it, it will happen at some point. If we have tomorrow a young patient or relatively young patient with a new diagnosis of AML, proliferating acute myeloblastic leukemia, and the patient had fever, and the patient is COVID positive, and you have the 1,000 blasts, how would you deliver the therapy? Because I believe we cannot wait in such a patient and say, well, okay, we'll come back later. This is part of the emergency. So how did you organize this for this type of patient?
Yeah, so actually this is what happened, because unfortunately hematological malignancies are not decreasing facing the COVID. So for a newly diagnosed patient who is also COVID positive, we start the treatment with no delay according to the indication for induction therapy. And it's very important to consider that we have to deliver the highest care for those patients with this kind of dramatic disease. So this brings to what could be considered an urgent indication rather than a non-urgent indication. And so for those patients, we explain the patient and that he will need to have his chemotherapy with the treatment of the COVID complication. But if he is highly proliferative and we cannot delay, we keep with the appropriate treatment in this case. And also coming back for what is considered like the possibly the non-urgent situation, one thing that was important at the beginning of the outbreak of COVID was that we were thinking not having any more access to the unrelated donor transplantation from abroad. So this because of the reorganization of the entire flight, and this was like very dramatic at the beginning. But then we, since this is becoming a world of the entire world program, some keeping the strong contact with the registry, the donor registry is very important, because we can still have some related donor graft which arrive with dedicated flight or also with some special transportation. But also in our unit, we start thinking of having always an haploidentical donor as backup, because an haploidentical donor can do all the tests in one day, staying in his, also if it's from another city, staying in the city and providing all the tests over there, and also search also for unrelated cord blood from national banks, preferably, because this would be also a strategy of backup from in case of the unrelated donor cannot join. So I mean, there are simple things that we can do to make safer our activity, but not change the program. If a patient have a 10 of 10, we try to have this 10 of 10. But in case of major disruption or the donor gets sick, in that case, we can have another donor that was already ready as backup, either the cord of the haplo. But so, this is very important.
So my understanding, and I think this is very reasonable and important, you are using all tools to be on the safe side and to be ready for any scenario. And this is the reason why you continue to search for unrelated donors, but you try to secure, if you have a family haplodonor, and why not cord blood units as backup. So let me ask you a very practical scenario. We didn't encounter this, but maybe you have already this experience. Assuming you are going for a haplotransplant and you have started your conditioning regimen in this patient, and then at time of stem cell mobilization, or let's say stem cell donation by the donor, this donor has fever, has cough, and you suspect that the donor himself is infected, because despite all the protective measures and so on, this poor donor, got the infection. First of all, did you see this scenario? And second, how would you handle this?
So actually, we didn't see this scenario because we avoid to start the conditioning regimen before having the graft in. And
so
this is
another
very
level of security, avoiding the chemotherapy initiation before securing your graft. I like this.
Yeah. So even in case of haploidentical donor, because an haploidentical donor can get sick, and the scenario that you face is actually something that really could happen, because we had a spread of the COVID-19 over the last week that was very, very, very impressive. So we start mobilization. We then do the apheresis, because we used to have peripheral blood stem cell as graft product, and then we cryopreserve it. The day of the cryopreservation, then we start the conditioning regimen in order to secure the delivery of the graft into the patients in a safe condition. And this is also the case for the unrelated donor, of course, and more, and also for cords. So we wait the cord to come, and then we start conditioning regimen. And also, I mean, this is very, very important, because delaying of 1 week, it's really more practical than having to face a situation where you have no more the donor available. So it's really important. And also another important point when we thought of our organization was to provide, to think to have also some doctors and nurses of backup, because in case of all the doctors and nurses get sick. And this is something in Italy we are facing really a high level of doctors and care delivery, people who drive the emergency car, who get sick due to the COVID. So this is very, very important. And we try at the first moment of having any symptoms, we stay home. But staying home, it doesn't mean that you don't work, because for our colleagues who are staying home are those in charge of doing the telemedicine, or organizing the activity for preventing those patients who can be sick. So this is and really at the first symptoms, we stay home, we do the nasopharyngeal swab, and we wait for the response until come back to the hospital. And of course, for those who are sick and not symptomatic, but with a positive swab, they stay home without any risk of contaminate, because actually you can not have symptoms, but then spread the virus very, very intensively.
So let me go back to this issue of telemedicine, but also the stem cell transplant patient and so on. So we discussed the issue of the conditioning, the trying to get secure the graft. But then if we have patients who are being treated, let's say for chronic GVHD and receiving steroids, and they have heard, of course, about the deleterious impact of steroids in case of a COVID-19 infection, and they are calling you, you know, and asking for advice, and they want to stop their steroids, or they want to start something else. What is your attitude in this situation?
Yes, as you say, I think that probably the telemedicine will change our life, because we are more and more in contact with our patients. But this is very important, because as we are anxious, they are anxious even more. So the issue of treatment, and it's of utmost important. And we are recommending not to stop any therapy that was prescribed by the hematologist, especially the immunosuppression. I mean, there are still not so many data, but we strongly believe that also for patients who are under treatment for their chronic GVHD, we have to keep they have to keep their treatment until new recommendation. So absolutely not stop any kind of treatment and any immunosuppressive treatment in these cases. So it's very important.
So my last question, Annalisa, is because in Italy the situation has been extremely dramatic, and I believe the level of psychological impact on healthcare professionals, on patient families, and the general population has been extremely high. So, what kind of support your institution started to provide to the healthcare professional? What kind of support you as a hematology department established for the patients, their families? Any clues, any tips you can give to the community?
Yes, actually, we in our we start from the hematological side. So in our unit, I mean, we used to follow the hematological patients like a big family. So we keep calling them, and they can call us and also we provide a psychological support done by our psychologists that cannot go into the room for the patients, but they are available over the phone, by email, several times per day, wherever they want. So this is important, and we strongly recommend also to the families of the patients who cannot go and see them and provide everyday care to contact and to share their feeling of frustration with the psychological staff, and also with us and with the nurses, in order to be able to don't feel that they are not following their relatives enough. And also into the hospital, we have a restructuration of the unit, and we are now creating a follow-up clinics for those patients who are treated for the COVID, also considering the burden of psychological and also neurological impact of this disease. So this is well structured and will cover also those physicians who want to treat them, be followed also for these cases. And it's very important because also the recommendation that I like to keep and to repeat: stay at home, wash your hands, and use your mask. It's very important, and the social distancing is really the key for avoiding the spread of this virus more. So it's really a change in our lifestyle, but it's crucial for being successful.
Well, that was really an amazing conclusion. Once again, thank you very much, Dr. Ruggeri, for sharing your insights, your experience. I believe you have done a terrific job. And actually, despite the crisis, despite the emergency, it is clear that the hematology workforce continues to deliver state-of-the-art therapy to all our patients. Obviously, we need to be creative, we need to reorganize things, but we can see very well that we can do it. And actually, the secret is to unite all our forces. And I believe we learned a lot tonight from your experience. Again, thank you all for joining this special webinar by the International Academy for Clinical Hematology. We will continue this special series as long as needed to support our colleagues and to spread and disseminate the knowledge. We will be happy to take your questions, but I do apologize in advance because in the previous webinars we had more than 100 questions each time. And for the sake of time, unfortunately, we cannot spend the whole evening, but I'm sure Dr. Ruggeri, myself, all the other speakers can reply to emails whenever it's needed. So thank you very much, and please submit your questions. Thank you.
Thank you, Mohamad. Thank you, the International Academy for Clinical Hematology, and please send your email and question whenever you want.